What if I told you that the absolute deadliest weapon in a 19th century hospital wasn't, a rusty scalpel or a contaminated surgical saw?
Right,
It
yeah.
was actually simply the doctor's bare hands.
I mean, it sounds like a horror movie premise, honestly, but it is a complete historical reality.
It really is.
Yeah.
So today we are taking a massive stack of sources. We've got medical history texts, modern infection control guidelines from the World Health Organization, decades of epidemiological
The
data.
heavy hitters, basically.
Exactly. And our mission today is to explore the single most powerful, high return on investment intervention in all of medicine. We're looking at a practice that acts as like the ultimate cheat code for human health.
Oh, absolutely.
It seems way too simple to be our primary defense against disease, and yet it absolutely is. We are diving deep into hand hygiene.
What's fascinating here is the core underlying logic at the center of this practice. If you think about it from, well, a biological perspective, hands are the ultimate vector. They are the primary vehicles transporting microscopic threats everywhere, from person to person, surface to surface.
Just a constant transit system for germs.
Exactly. So if you can break the chain of transmission right there, with the hands of catechus, you don't even need to heavily control the broader environment, or the air, or, the entire microscopic ecosystem around a vulnerable patient.
You just stop the transport mechanism?
You cut it off at the source.
Okay, let's unpack this. Because to really grasp how powerful this cheat code is and why it's so vital for you to understand the mechanics of it, we have to travel back to a time before anyone even knew what a germ was.
Oh, the dark ages of medicine.
Truly. We are going to the 1840s, the Vienna General Hospital to be exact. And the situation we're looking at was, frankly, just a nightmare.
It was an absolute tragedy. We're looking specifically at the hospital's maternity wards. At the time, this massive hospital had 2 separate maternity clinics.
Right next to each other.
Yeah. The first obstetrical clinic was staffed primarily by male physicians and medical students, and the second obstetrical clinic, literally next door, was staffed entirely by female midwives.
Okay.
And Dr. Ignaz Semmelweis, a Hungarian obstetrician working there, began to notice a horrifying pattern in the data.
A pattern that was costing lives on a massive industrial scale. I mean, the maternal mortality rate from puerperal fever, which they colloquially called childbed fever, in the first clinic, the one run by the highly educated doctors, was astronomical.
Unbelievably high.
It regularly exceeded 18%.
Wow.
Yeah, nearly 1 in 5 women walking through those doors did not survive. Meanwhile, the midwife's clinic right next door had a mortality rate hovering around just 2%.
The disparity was so stark, and the data was so widely known in the surrounding community that pregnant women were absolutely terrified of the doctor.
Don't blame them.
Right. The historical sources document that women would literally drop to their knees and beg, just plead not to be admitted to the first clinic.
And reading through these historical texts, there is one detail that it stopped me in my tracks. Women were deliberately having what they called street births.
Yeah, that's just wild.
They would intentionally give birth in the filthy cobblestone streets of 19th century Vienna, just so they could legally claim they were, en route to the hospital and totally bypass the doctor's clinic altogether.
And the crazy part is, the data actually supported that decision.
Yes. The street births actually had significantly better survival outcomes than going to the elite physicians.
So Semmelweis is looking at this undeniable statistical anomaly, and he starts trying to isolate the variables, like a good scientist. Both clinics shared the same building, so it wasn't the climate.
Right.
It wasn't the overcrowding, because the midwife's clinic was actually more crowded due to women actively avoiding the doctors.
That makes sense.
It wasn't the diet either.
Yeah.
He eventually zeroes in on a major difference in personnel behavior. The physicians and medical students in the first clinic had a completely different daily routine than the midwives.
Right. And here is where I have to just stop and ask, because I was appalled on behalf of anyone listening to this right now.
They're pretty gruesome.
If I'm reading this right, the doctors were spending their mornings doing autopsies in the hospital morgue, like literally elbows deep dissecting cadavers.
Yes.
And then they're just wiping their hands on a rag and walking straight up to the maternity ward to examine laboring women?
That is exactly what they were doing.
I mean, how did no one connect the dots? Just based on the sheer visible grime. Didn't anyone look at their hands and think, hey, maybe this is a bad idea?
It's a completely natural question for us to ask today, but you have to actively put yourself inside their 19th century paradigm. The germ theory of disease simply did not exist yet.
It wasn't even a concept.
No, not at all. Louis Pasteur and Robert Koch wouldn't do their foundational work proving that microorganisms cause disease for, like, another couple of decades.
Oh, wow. Okay.
In the 1840s, cleanliness was considered a vague, moral, or, aesthetic virtue. It wasn't a scientific, mechanistic requirement.
So it was really about class, not biology.
Exactly. A gentleman doctor inherently believed his hands were clean simply because he was a gentleman of high social standing.
That is wild.
And the prevailing scientific theory of the day was the miasma theory. This was the idea that diseases were caused by bad air or foul-smelling vapors coming from rotting matter.
Ah, the bad air.
Right, yeah. So the idea that a high-status doctor could physically carry invisible death on his hands was fundamentally absurd to them.
But surely, the data was screaming at Semmelweis. What finally gave him the biological clue he needed?
It took a very personal tragedy, unfortunately. In 1847, a close colleague of Semmelweis, a doctor named Jacob Kolechka, was accidentally punctured with a student's scalpel during a morgue autopsy.
Oh, no.
Yeah, he died shortly after. And his own autopsy revealed pathological changes like severe internal damage that were strikingly, unmistakably similar to the women dying of childbed fever in the maternity ward.
Oh, my God. It was the exact same disease pathway, but in a man.
Yes, and that was the breakthrough moment. Semmelweis realized that the doctors were carrying what he called cadaverous particles, because he didn't have the modern vocabulary for germs or bacteria.
Right.
He realized they were carrying these particles from the dead bodies directly into the living, vulnerable bodies of the mothers.
So he institutes this massive intervention. He creates a new rule forcing the physicians and students to wash their hands in a chlorinated lime solution before examining any patients.
It was a big deal at the time.
And what's wild is he didn't even choose chlorinated lime for its antibacterial properties. He only chose it because it was a chemical strong enough to get the smell of rotting flesh off their hands.
Right, to combat the miasma, the smell.
Yeah, exactly. But the result is completely undeniable. The mortality rate in the first clinic plummets from that horrific 18% down to under 2% in about a year.
It's an incredible drop.
He successfully matched the midwives' outcomes.
And we should note, he wasn't entirely alone in sensing this broader pattern. Over in the United States, Oliver Wendell Holmes Sr. was arguing around the exact same time that doctors were transmitting disease from patient to patient.
Based on tracing case clusters, right?
Yes. And slightly later, Florence Nightingale revolutionized hospital survival rates during the Crimean War through incredibly strict sanitation and hand-washing protocols.
Though she was still operating under the miasma theory, right? Like, she thought she was just clearing out the bad air.
She was.
Yeah.
But her practical interventions worked mechanically. Even if her underlying theoretical framework was incorrect, she was physically removing the pathogens.
Okay, but unlike Nightingale, Semmelweis ran what was essentially a naturally occurring, tightly controlled experiment. He dropped the mortality rate to 2%.
Yeah, the hard numbers.
Yeah, so logically you'd think the medical community would have thrown a parade for the guy. But they didn't. Which brings up a fascinating psychological puzzle. If he proved this with undeniable life-saving data, why wasn't he immediately hailed as a hero?
Because the medical establishment of Vienna entirely rejected his findings.
It's just so frustrating to hear.
It really is. And the reasons why provide a masterclass in human psychology and institutional stubbornness. First, as we mentioned, there was no accepted biological mechanism to explain his data.
They couldn't see the germs, so they didn't believe the data.
Right. But more importantly, the senior doctors were deeply, fundamentally insulted.
They took it as a personal attack on their character.
Highly personal. Semmelweis was essentially standing up and telling the most respected, elite physicians in the city that they were the ones actively murdering their own patients.
That's a tough pill to swallow.
And to make matters worse, his communication style was incredibly combative. He publicly called his critics murderers.
Oh, wow. Yeah, that won't win you any friends.
No, he totally alienated the very people whose behavior he needed to change.
It makes me think of an analogy for you listening right now. Imagine going up to a modern elite software engineer at a massive billion-dollar tech company, and you prove to them with data that for the last 10 years, their specific, beautiful, elegant code has actually been quietly injecting destructive viruses into their own company's apps.
That would not go over well.
Not at all. Even if you show them the diagnostic logs, their professional egos just couldn't handle it. The cognitive dissonance would be too loud. They'd rather believe your diagnostic tools are broken than admit they are the root of the problem.
That is a perfect parallel. The establishment ultimately drove Semmelweis out of the profession.
Uh,
His career collapsed. He suffered a severe mental breakdown and was committed to an asylum.
so sad.
And in a twist of truly dark, tragic irony, he died there in 1865 from sepsis, which is a systemic wound infection, after being beaten by guards.
Wow. He died of the exact same systemic infection he spent his life trying to prevent in those mothers.
Exactly. But his failure left a permanent mark on the philosophy of science. If we connect this to the bigger picture, it birthed the psychological term we still use today, the Semmelweis reflex.
The Semmelweis reflex.
Yes. It describes the institutional tendency to reject paradigm-shifting evidence simply because it contradicts established norms or, threatens professional identity without ever actually evaluating the evidence on its merits.
So Semmelweis failed to convince his peers because he lacked the underlying biological proof, the germ theory. But what happens when we do get that proof?
Right.
Fast forward a century. Thanks to Pasteur and Koch, we map the microscopic world. We have Joseph Lister's legacy of antisepsis. We have electron microscopes. We know exactly what germs are and how they kill.
The science is totally settled.
Right. So you'd assume that by the modern era, we must be absolutely perfect at hand hygiene in hospitals.
Right, you would certainly hope so. But the modern epidemiological data tells a very different, very sobering story.
Uh-oh.
Yeah. Even today, global compliance with hand hygiene protocols among trained healthcare workers historically hovers around an abysmal 40%.
Wait, I have to pause here. 40%.
40%.
That's a failing mark in literally any school on earth. If you're listening to this and thinking, wait, the person drawing my blood or checking my vitals might only have a 40% chance of having washed their hands, you aren't alone. I am genuinely confused.
Just shocking, I know.
If you are a highly trained nurse or doctor and you literally know the science, you know you could cause a fatal hospital-acquired infection, why would you ever skip it? Is it just simple laziness?
That is the assumption most people make. And honestly, it's what hospital administrators assumed for decades. But it's fundamentally incorrect.
Really?
It is not a knowledge problem, and it is definitely not a laziness problem. It is a systems and workflow problem. This is a classic example of what researchers call the knowledge-behavior gap.
Okay, explain that gap to me, because right now it just sounds like negligence.
To understand it, you have to think about the immense cognitive load and the physical layout of a busy hospital ward. Think about a nurse on a standard 12-hour shift. They're moving constantly, continuously bouncing between patients. They're interacting with complex 4V pumps, silencing alarms, checking monitors, grabbing supplies.
Sounds exhausting.
It is. If the protocol requires them to walk to a physical sink, turn on the water, lather with soap, rinse, and dry their hands with paper towels every single time they cross one of those invisible boundaries between patients, they might realistically have to do that 50 or 60 times an hour.
Oh, wow. Wait, an hour?
Yes. The sheer physical friction of that workflow makes compliance mathematically and physically impossible while keeping up with urgent patient care. You'd spend your entire shift standing at a sink.
Wow. It's like a hospital telling you that physical fitness is mandatory for the job, but they lock the only gym in the basement behind a rusted door that takes 10 minutes to open.
Exactly.
The environment is actively fighting against the behavior they are demanding.
Precisely. The system was designed for failure. And that realization brings us to the 1990s and an epidemiologist named Dr. Didier Pittet at the Geneva University Hospitals. He recognized that lecturing exhausted staff wasn't working. His genius was treating this as a design flaw, like an engineering problem.
A workflow issue.
Yes. He shifted the entire hospital's focus away from traditional sinks and instead introduced alcohol-based hand rub, or ABHR, right at the point of care. He put it on the end of the patient's beds, in the nurse's pockets, literally everywhere.
Oh, so he completely removed the friction from the workflow.
Exactly. And the study they published in The Lancet in the year 2000 was absolutely groundbreaking. Just by changing the system and making the right choice the easiest choice, compliance jumped from 48% to 66%.
That's a huge leap.
And crucially, hospital-acquired or nosocomial infections dropped from roughly 16.9% of patients down to 9.9%.
That is a staggering drop. We're talking about thousands of lives saved simply by moving the sanitizer 3 feet closer to the bed.
And that exact data from Geneva became the evidentiary backbone for the World Health Organization. In 2009, the WHO launched their Global Save Lives campaign and formalized what is now the absolute gold standard in medical training, the My 5 Moments for Hand Hygiene framework.
Right. I saw this in the sources, and it completely redefines how we think about cleanliness. It wasn't just the old aesthetic standard of, wash your hands when they look dirty.
Not at all.
It became a strict discipline embedded into the actual sequence of clinical care. The 5 moments are 1, before touching a patient, 2, before a clean or aseptic procedure like inserting an IV,
Right.
3, after exposure to body fluids, 4, after touching a patient, and 5, after touching a patient's surroundings like their bed rails or their monitors.
That fifth moment is absolutely critical. From an epidemiological standpoint, the bed rail or the tray table is biologically an extension of the patient.
Really?
Yeah. If you touch the rail, you have effectively touched the patient's microscopic ecosystem.
Right.
The germs don't recognize the boundary between human skin and plastic.
Here's where it gets really interesting, though. Because if bedside alcohol rub is the modern standard, and it's so fast and it saves so much time, does that make old-fashioned soap and water totally obsolete? Like, are hospital sinks just decorative at this point?
Not at all. And this is a massive debate that gets misunderstood by the general public all the time. Soap versus sanitizer.
Okay, break it down for us.
So for the vast majority of clinical situations, alcohol rub is actually preferred by guidelines. It's faster, it has a broader spectrum of microbial kill, and paradoxically, it is actually gentler on the skin over the course of a long shift.
Wait, rubbing alcohol on your hands 50 times a day is gentler than soap. That doesn't sound right.
It does sound counterintuitive, but yes.
Ah.
Because modern medical hand rubs contain emollients and moisturizers. Constant washing with soap and water strips the natural oils from the skin, leading to severe contact dermatitis.
Which is like painful cracking, redness, and inflammation.
Exactly. When a nurse's hands are cracked and bleeding from dermatitis, they naturally want to stop washing them. Alcohol rubs prevent that breakdown.
Okay, that makes perfect sense. But there is a biological exception where alcohol completely fails, right?
Yes. And to understand it, we have to look at the actual mechanisms of how these tools work. Alcohol kills by essentially acting as a chemical wrecking ball.
Okay.
It rapidly dissolves the lipid envelope, the fatty outer layer of many germs, and just scrambles their internal proteins.
Yeah.
But that chemical mechanism completely fails against spore-forming organisms like Clostridioides difficile, commonly known as C. diff.
Right.
It is also much less reliable against what we call non-enveloped viruses.
I'm going to need a translation on that. What does non-enveloped mean?
A non-enveloped virus, like norovirus, which is the famous stomach bug that rips through cruise ships, doesn't have that fatty lipid outer layer that alcohol easily melts.
Oh, I see.
Instead, it is protected by a very tough, resilient protein shell. And C. diff spores are essentially armored biological bunkers. Alcohol just washes right over them.
So it's like alcohol is basically poison gas for most germs. It melts them on contact. But C. diff and norovirus are basically wearing microscopic hazmat suits. The poison gas does absolutely nothing. So instead of trying to chemically poison them, you have to physically shove them out the airlock.
That is a highly accurate way to visualize it. You need mechanical removal, friction, and rinsing.
The physical action.
Exactly. The physical action of the soap molecules binding to the pathogens, lifting the spore off the skin, and the water flushing it down the drain. If a patient is known or suspected to have a C. diff infection, alcohol rub is totally useless.
Wow.
You must walk to a sink and use soap and water. They're entirely different tools designed for completely different biological problems.
Which clears up a massive misconception. But diving into the WHO guidelines, there are a few other dangerous myths that even trained healthcare workers sometimes fall for.
Oh, absolutely.
One of the biggest is the idea that visibly clean means hygienically clean.
Right. It's a dangerous cognitive bias. Pathogens are microscopic. Your hands can look immaculate, like perfectly clean to the naked eye, but they might still be loaded with a lethal dose of transient bacteria.
And just to clarify for everyone listening, transient bacteria refers to the germs we pick up from our environment, right? Like microscopic hitchhikers, as opposed to the resident flora, the healthy bacteria that naturally live deep in our skin layers as locals.
Exactly. You are trying to wash off the dangerous hitchhikers before they get off at the next stop, which might be a vulnerable patient's surgical wound.
Yes.
Yeah. Visual inspection is a completely invalid proxy for microbial load. That is exactly why the WHO's 5 moments dictate when you clean your hands based on the workflow, regardless of how clean they appear.
And then there's the glove issue. I see this one all the time, even just out in the world, at the grocery store or a restaurant. People think that if they're wearing gloves, they're completely safe and they don't need to wash their
It
hands.
creates a huge false sense of security. Gloves get microscopic tears all the time during normal use.
Oh, really?
Yes. Furthermore, the outside of the glove becomes heavily contaminated, and the complex physical act of peeling them off frequently contaminates the wearer's bare hands in the process.
So you're just getting the germs right back on your hands anyway.
Exactly. Infection control guidance is incredibly strict on this. Gloves do not replace hand hygiene. You must perform hand hygiene immediately after removing them. They are complementary layers of defense, not substitutes for one another.
So bringing all of this together, what does this all mean for you listening right now? Maybe you don't work in a hospital. Maybe you aren't prepping for a nursing exam. Though if you are, know that this is literally the very first clinical competency you will be assessed on.
Without a doubt.
Hospitals are heavily, rigorously audited by accreditation groups on this exact metric because it remains the highest return on investment practice in all of medicine.
But even outside the clinical environment, this logic governs our everyday world.
Exactly. Think back to the very beginning of the COVID-19 pandemic. Before we had mRNA vaccines, before we had complex antiviral treatments, public health authorities worldwide revived the exact logic of Dr. Ignaz Semmelweis from 1847.
Interrupt the transmission at the point of contact. Wash your hands.
Yep. And it's just as relevant every single winter when we try to prevent the seasonal flu, colds, or those massive norovirus outbreaks we mentioned earlier.
The fundamental science of breaking the transmission chain doesn't change, whether you are in a 19th century maternity ward or a modern elementary school.
But looking at all these sources, there is a deeper lesson here too,
Right.
one that goes far beyond biology and strikes right at human nature and professional pride.
This raises an important question, and it's one we want you to really mull over. We spent a lot of time talking about the Semmelweis reflex.
Right, the elite Viennese medical establishment actively ignoring undeniable data that could have saved countless lives simply because accepting it hurt their professional pride.
They couldn't stomach the idea that their current respected methods were actually the root of the problem.
So the question we want to leave you with is, what is the dirty hands equivalent in your industry right now?
Exactly. What undeniable, paradigm-shifting data are you or your colleagues collectively ignoring today simply because it challenges the way things have always been done?
It's a tough question.
What is the obvious, life-saving, or business-saving truth that your professional ego is currently rejecting?
Because as we've learned from the tragic history of the maternity wards of Vienna, the ultimate cheat code for survival only works if you are actually willing to look down and acknowledge the grime on your own hands.